We'll move into our first debate in this session. There's two debates in this session, and I think we started talking about this topic a little bit in the morning. And that's a question of how long to treat with immune checkpoint blockade. Of course, there's costs associated with treatment, not only patient cost, time, side effects, but lots of cost to the healthcare system. And it's very important to try to figure out when we can stop, especially in responding patients. So I have two different people taking two different sides of this issue. And the first would be Dr. Allison Betof Warner, who is going to be taking the side of we should treat all patients with PD-1 for at least 2 years and possibly forever. So Allison, and then this will follow from the other side of stopping patients earlier based upon certain response metrics. So Allison?
Great, thanks, Mike. So now that Mike has made Dr. Shoustari's points for him, I'm going to try to argue that we should stay on PD-1 longer than we may be currently doing. So I have no disclosures. So how long should we really stay on PD-1 if it's working? And my answer to you, or at least I hope by the end of this, will have partially convinced you that the answer should be at least 2 years and possibly forever. So why is that? So we heard lots of good reasons why you might want to stop, right? Cost, patient convenience, late toxicity. I'm going to argue the other side of this, right? The first point being, we don't know how much PD-1 is enough, or really, said another way, how little is too little, right? Is 1 month enough? Is 2 months enough? Is it 1 year? We really don't have a lot of data, and I'll go into what we do know. The second point here is we all talk about toxicity and stopping PD-1 therapy to prevent toxicity, but late toxicity with these agents is actually quite rare. And the last point here is, when we think about stopping a therapy, right, we have to know what we're going to do in the case of progression or recurrence. And I'm going to show you some data that we have from our group and some that have been published that really suggest that we don't have very effective therapy in many cases for these patients, therefore suggesting that we may need to consider staying on therapy. So to talk about our first point, how much is enough? So we have some retrospective data, these are mostly from melanoma, that suggests that 2 years is probably enough in patients who have a complete response. However, the only prospective data we have are in non-small cell lung cancer that actually argue the opposite, that staying on PD-1 therapy for longer is probably better. So let's start with these. So this paper came out last year in the Journal of Clinical Oncology. It is Caroline Robert's paper that looked at 655 patients who were treated with pembrolizumab, about 105 of which had a complete response. And if you look on the left here, you're seeing disease-free survival. The x-axis here is time since achieving CR, right? And what we see is that there is degradation over time, right? Disease-free survival does decrease over time. And if we look at time since stopping therapy, right, we see that over time that does continue to trend down. The median time on PD-1 in this trial was 23 months. So overall, most of these patients did pretty well, right? 87% of the patients who had a complete response had discontinued PD-1. 88% of the patients remained disease-free at a median follow-up of 30 months, which is pretty impressive. And at 2 years, the estimated disease-free survival rate from CR was 91%, arguing that maybe that 23 months or 2 years of therapy really was sufficient to consolidate this response. Now, would less have produced the same results? We don't know, right? If these patients stayed on therapy longer, would these numbers be better? We don't know. This may also just be intrinsic resistance that would have developed whether or not the patient stayed on therapy or not. I'm going to show you some data from our group, however, that take patients outside of a clinical trial setting. So we looked at 396 patients at Memorial who were treated for melanoma with PD-1 monotherapy. 102 of those patients had a complete response. And on the left here, we see our overall survival curves. On the right, you have time to treatment failure or duration of response. And in our cohort here, the median time on PD-1 was 9.4 months. So 75% of these patients were treated outside of a clinical trial, meaning that in our perspective, this is much more of what really happens in our clinic, right? We perceive that a patient has had a complete response, either radiographically or we biopsy and we get a negative biopsy, and we go on to, at some point, discontinue PD-1 in many of these patients. What we see here, however, is that at 3 years, right, the median duration, at 3 years, right, only about 72% of these patients remain disease-free, right? Says that it's, so then we think that, I don't know, was it stopping early? I don't know. Is it just a different patient population? It's unclear to me, okay? But these are some real-world data here from our patients here at Memorial. So in non-small cell lung cancer, this was looked at prospectively in a randomized trial. So they took patients who had advanced non-small cell lung cancer, who had had treatment for 1 year with nivolumab, and had some form of a response, whether that was stable disease, partial response, or complete response. And they randomized those patients to either staying on nivolumab or stopping nivolumab after a year. And they did allow retreatment with nivolumab if the patients were to go on to have progressive disease. So just to get a sense of the numbers, they had 76 patients who stayed on continuous nivolumab and 87 who had discontinued at 1 year on the trial. And what we see is when we look at all of these patients together, the patients in blue are the patients who stayed on nivolumab for longer than a year do significantly better. We're looking at progression-free survival. Now, one could look at this and say, well, what if that's just the stable disease patients who maybe should have stayed on, right? You weren't really looking at responders. So if we break this down, right, the stable disease patients who stay on treatment certainly do better, but so do the patients who had either a complete response or a partial response. So this trial did not look at staying on for 2 years, but at least in the non-small cell lung cancer population, staying on for greater than 1 year was better than stopping at 1 year, at least when we look at progression-free survival. So let's move on to the second point here. So we talk a lot about toxicities from checkpoint inhibitors, and checkpoint inhibitors have very significant toxicities. And we think a lot about stopping to prevent toxicity, or at least to prevent toxicity from getting worse over time. However, if we look at this study that was published in JCO in 2016, we see that most of the toxicities, this is nivolumab, most of the toxicities actually happen in the first 3 months on therapy, right? This is weeks, just to point out, on the x-axis, right? So if we are thinking out to 2 years, right, we are well beyond the range of most of these common toxicities. So do toxicities occur late? Some do, right? And here's some other data from the same paper that looks a little bit further out to 96 weeks. And occasionally we will see a late toxicity, at least here, out to about 52 weeks. But there's a significant degradation in the amount of toxicity that we see over time. So if a patient has not had toxicity at 2 years, the chance that they're going to really have significant toxicity that should motivate you to stop PD-1 therapy is pretty low. And to come to the last point, what are you going to do when these patients progress or recur in the case of complete responders? So we don't have a lot of data in this realm. We have a small number of patients that have been published on to date. So from the Keynote 006 trial, these are all melanoma patients. 8 patients were retreated after progression. These were all patients who had a complete response to their first course of treatment. And 4 of those 8 patients had some response to retreatment. That was actually really promising, right? 50% of these patients responded to retreatment. However, the number's pretty low. In Keynote 001, right, 4 patients were retreated. Only 1 of those 4 had a response. And again, all of those were patients who had had a complete response to their first course. More recently, a larger cohort of patients has been published on 19 patients. And this was still a clinical trial population, But they did include patients who did not have a complete response to their first course. So they included patients who had a partial response or even stable disease who had stopped PD-1 therapy. And only 6 of those patients, or 32%, had responded to retreatment. Again, these are all clinical trial patients. So I wanted to take a look at what happens sort of, again, in our patients off clinical trial. So I took that same cohort I described to you earlier, our 396 patients, and looked at every one of those who had gotten a second course of PD-1 therapy at least 3 months after stopping their first course. Right? And overall, we had 34 patients who were retreated. 20 of them had progressive disease, 9 had stable disease, and we only had 5 responses. Very interestingly, right, the first response did not predict the second response. So if you look along the bottom, right, the left column here is their response to their first course of treatment. So the patients who initially had progressive disease, 8 of them were retreated, right? 6 of them had progressive disease on retreatment, but 2 actually responded. Right? In contrast, 8 patients who had had a complete response to their first course of therapy were retreated. None of them had a complete response the second time, right? And only 1 responded. We actually had an overall response rate from this cohort of 15% to retreatment, which was somewhat surprising. We've now compared this to patients who were retreated or escalated to IPI plus Nivo, right? And they had a 25% response rate. Still not super reassuring if you're considering stopping a patient who is responding to your therapy and tolerating it well and not expected to have significant toxicity going forward. We also have some data from that same lung cancer cohort that were presented on retreatment. So the same 76 patients that had continued and then 87 stopped nivolumab. 34 of those patients were retreated with nivolumab as well. And what you can see here is, this is a slightly confusing way to present the data, but the black dots are the point at which the patients started retreatment, okay, their second course of treatment. And what we see here, if you just take an overall trend, is everything is trending up. All the tumors are getting bigger. 1 or 2 are shrinking, okay? But the response to retreatment is very poor. And it's not something that we can rely on and just tell our patients, we can stop PD-1, and if you progress at some point, we'll just restart it, which I think many of us have said at some point, but the data suggest exactly the opposite. So I hope that I've at least started to convince you that we need to stay on PD-1 a little bit longer than at least our 9.4-month average that I presented from our data here, because we don't know how much is enough. Because late toxicity is quite rare, and because what are we going to do when these patients go on to progress? Okay, so thank you, and I'll turn it over to Dr. Shoustari.
So Alex Shoustari is coming now with the viewpoint that we should stop earlier. And he's wearing his pink debate jacket, so guaranteed for a victory tonight. Thank you, Alex.
I knew it'd be
and,
dark here, so.
Yeah, thank you for participating. And then after this, we'll have another debate about adjuvant and neoadjuvant treatment, and then we'll have a panel discussion where we can talk about all the topics that were raised in this session.
All right, thanks, guys. I was wondering if... Good, okay, the pointer will work. So thank you to Dr. Betof Warner. Thank you to Dr. Postow for inviting and organizing this. Truthfully, I actually kind of agree with the other viewpoint. So it's kind of a nice rhetorical exercise to sort of, try to put yourself in someone else's shoes, which I don't like to do politically or in any other field of my life. So it's good to do that here. Probably the only disclosure worth mentioning is Bristol Myers Squibb, where we do work with them. So that's obviously related to nivolumab. So why should we limit PD-1 exposure? I'm going to ask you to sort of reimagine how we've done these clinical trials. And I'll do it mostly with words. I actually don't have too many slides, but these are the 4 main points. The antibodies linger for a long time. The immune system itself is the drug rather than the number of infusions that we actually give. And then we do have ways to sort of predict whether people will do well or not. I don't think it should be a blanket sort of judgment on how long someone should be on treatment. And then lastly, I'm just going to highlight how much we really don't know about the long-term effects of these treatments that we're trying to convince our patients are relatively benign compared to chemotherapy. So this is one of my favorite slides to show almost everybody for almost any reason whenever I talk about PD-1 blockade. And this comes from the phase 1 trial of nivolumab, where in yellow at the very bottom, because this is JCO, back then it's just branded yellow and blue. And so the yellow is the pharmacokinetic sort of concentration of nivolumab. And you can see that one dose, these are 4 patients getting 1 dose, that you see that rise and fall, and the rise and fall kind of happens around 3 weeks, and so they decided to give their drug every 2 weeks based on the pharmacokinetic data. But because PD-1 is a membrane protein, and you can actually look at the amount of that protein that has a nivolumab latched onto it, you can actually calculate how much of the receptor is occupied. And again, after 1 dose, you can see a relatively high and constant sort of occupancy that's nice and flat for several, in this case, 2 to 3 months, where they measured it out a little bit longer. So 1 dose lasts a lot longer than every 2 weeks. And so one point to make is that on the trials, we were dosing it just like a chemo drug. Hey, a cycle is 3 weeks, a cycle is 2 weeks, a cycle is 4 weeks, and let's give you the drug every single time. In reality, we don't have to do that to our patients. We don't have to necessarily give it every single time right on time. And when you look at multiple doses, this effect is actually, fairly pronounced. This person got, 3 doses, and the occupancy didn't fall down to nothing until somewhere between 400 and 500 days. The second point, we know that the immune system is the drug, and that effect can linger long beyond the effect of the pharmacodynamics. So I've already mentioned the pharmacokinetics are short, pharmacodynamics are a little bit longer, but that sort of central memory effect can actually linger quite long. And so this is a paper that Mike actually spearheaded. He's the senior author of this paper, where they looked at, this is with Ipi-Nivo. So Allison cheated by talking about lung cancer. I'm cheating by talking a little bit about Ipi-Nivo rather than PD-1 monotherapy. Here you have in blue those that couldn't get any more treatment, and this is in the clinical trial era where once you're off, you're off. You're not getting any more drug. There's no other way to get the drug. They stopped treatment somewhere in the first 3 months. And here you can kind of use the immune system as your sort of, rheostat, as your sort of marker for whether you've overdone it or not. And if you've overdone it in the first 3 months, you stop. And then you look and see, compared to those people who didn't stop for toxicity, that they do relatively similarly. And the main sort of limitation of this analysis, which came out a couple of years ago, was that the follow-up wasn't super mature. It was only about a year's worth of follow-up before the line gets sort of hazy with a bunch of sensor marks. And so recently, the most important trial in melanoma field, Checkmate 067, the tree that gives New England Journal papers every year or two, recently came out with 5-year overall survival data. And this is a little bit indirect, but they looked at the same exact comparison. I mean, not the exact same comparison. They looked at the group that stopped for toxicity, and now we have 5-year follow-up. This is not, just a year later. And we see that overall, for Ipi-Nivo at least, the people who stop for toxicity have roughly the same sort of overall survival at 5 years. And so a lot of data, and I think rightfully so, has been focusing on PFS, because in the old days, PFS was a really, really good surrogate for survival in melanoma. I think what we're starting to see, and with our colleagues like Dr. Arian in surgery, and Dr. Barker in rad-onc, and our other colleagues, we can sometimes pick off these progressions and keep them, keep patients, relatively well. So in this case, at least for ipi-nivo, we have strong data, I would argue, that you don't need to sort of push through. There's not a set amount of time that you need to stay on. Now, this is the same data that Dr. Betof Warner showed us earlier. I like to show the swimmer's plots as opposed to the Kaplan-Meier curves. So admittedly, these patients were treated for a longer time than I'm supposed to argue that we're supposed to treat for. So they're treated for a median of 23 months, as she said. The median treatment time past their complete response was like 7 months, which is, are we okay? And they did quite well, depending on what your denominator is that you look at, because there's a couple denominators in this paper. You can find that progression-free survival as low as sort of 10%, as high as maybe 15%. And I think the data are pretty compelling that in a real-world setting, if you stop super early, if you stop right when you see the complete response, that progression rate is a little bit higher. That may be 25%. But I think we have another tool here. We have a radiographic response that we can look at and make that decision on a case-by-case basis. And so, again, the same data, I just had this slide ready to go, so sorry I didn't use the JCO paper here. But you look at the people who completed 2 years, even the stable diseases over the relatively few months there did pretty well. And this is progression-free survival. The overall survival data, as you would expect, looked even better than this. So I don't think the data suggests that we need to continue past 2 years just because we don't yet have the data. I think we can look at the pharmacodynamics and our emerging understanding of how the immune system works to regulate these cancers to argue that maybe 2 years is enough. Maybe this is good enough. Maybe progression isn't always death. Now, same data, argued slightly differently. So yes, late toxicities occur and they might be preventable. But what I would suggest is that we really don't know, just like we don't know, exactly how long to treat for, I think we really don't know what the long-term effect of this continued inflammation is. And what I'm pointing up, and I'm sorry I forgot to put the reference here. This is a paper from 2004 in the New England Journal that looked at the Framingham study, and they had some plasma, sort of banked, and they looked at things like high sensitivity CRP. They looked at IL-6, soluble TNF receptor 1 and 2. These are all markers that we know are elevated when we are on checkpoint inhibition, and they saw a really sort of linear relationship. So in the quintiles going across to the right, the higher your interleukin-6 and CRP are the ones I'm showing, the higher those rates were, the higher your overall risk of getting a myocardial infarction is. And I put this up not to say that, oh my gosh, we're definitely going to give people heart attacks, but I'm putting it up because we are naive if we expect that our good treatments, all they do is good. And I know no one's arguing that, but we're sort of looking at CTCAE grade 1, 2, 3, and 4, and we're saying, look, these grade 3 rates are so low, they're so rare. But if you ask a patient, hey, how do you feel at 18 months? You ask them, how do you feel at 24 months? Most of them say, I'm tired. But okay, if I gotta live, I'm tired though. But I'll live, doc. It's no problem. The question for us is, are we satisfied with that one-size-fits-all approach? Well, cancer's everything. Let's make sure you're in CR. That's the most important thing. What if we look back and we discover that we gave 20% additional risk of a non-fatal MI, revascularization, those kind of MACE endpoints in cardiovascular toxicity? This is just one piece of what I think is a larger puzzle. And so it's not solid data. So like, someone who's underprepared at a debate, I'm sort of just appealing to your emotion and hoping that you don't notice. But we don't have the data. But I think we need to be a little bit more open-minded to the harms that we do in the long run that are not captured by our CTCAE. And so this is my favorite part. So what we have to remember, hopefully this will launch in YouTube, is anybody here, I guess, does the sound work? I don't even know. But if you guys are Simpsons fans, this is one of my favorite lines from The Simpsons. We'll figure out if it's actually going to work or not.
Nothing can possibly go wrong. Possibly go wrong. That's the first thing that's ever gone wrong.
So it's the theme park of the future, itchy and scratchy land. Here in the theme park of the future, nothing can possibly go wrong. And I think that's kind of what we're going to start to see be a mistake. So in the long run. So anyway, to wrap up, hopefully that was not too far over. The antibodies stick around. The immune system itself can have long-acting sort of effects, both good and bad. And I didn't even include the data, for example, that using PET scans and not just CAT scans can really tease out the best group. So if you have a metabolic complete response, even if you're a partial or a complete response, if it's metabolic CR, we have small retrospective studies that show a 5% relapse rate over the following, I think it was a year and a half. So we can, figure out who's going to do the best and who's not going to do the best. I think we really need to start limiting the antibodies in the people that look like they're doing the best. One day we'll update our melanoma group photo because our two newest hires, one of whom isn't that new anymore, need to be in the photo. Thank you. You guys didn't like my Simpsons thing. All right.
And we love The Simpsons, Alex. Thank you. It was the first time anything went wrong. I think that part was hard to hear. Thanks.